Hey guys, my name's Suzanne. I'm a PA here at Bayside. We're going to go ahead and get things started. I think we got more people starting to log on here, but my name's Suzanne. I'm a PA. Been in orthopedics about 15 years now. Been at Bayside here for about 6. I know for the last few weeks here at Bayside, we've been trying to do some little Facebook webinar live events just to kind of give you some updates and give you some increase your knowledge and kind of answer some questions y'all may have. I know Dr. Detterman's done one on shoulder pain. I know our nurse practitioners have done one on osteoporosis last week, and Dr. Savage and myself have been doing a weekly one for the kids about various topics related to the musculoskeletal system. But today we're going to talk about osteoarthritis. What it is, how we treat it, how we diagnose it, why it hurts. So y'all feel free to answer any questions, and I'm hoping that as we go through this talk, we can answer answer any questions you may have. But let's go ahead and get started here. Osteoarthritis, arthritis. What is arthritis? Arthritis is a very vague and covers a wide scope of diseases, but arthritis by definition is simply inflammation of a joint. The ARTH, arthro, means joint. Itis just means inflammation, just like you can get tendonitis, which is inflammation of a tendon. Arthritis is just inflammation of a joint. They're common. There's several different types of arthritis. What we're going to be talking about today is osteoarthritis. There's also what's called post-traumatic arthritis. Sometimes you can clump that into osteoarthritis, but it's a little bit different mechanism. And then there's rheumatoid, psoriatic arthritis, gouty arthritis. Most people have heard of those before. Rheumatoid and osteoarthritis are two different disease processes. And we're not going to be talking too much about rheumatoid today. Rheumatoid can cause some similarities in symptoms related to osteoarthritis, and ultimate treatment of the large joints can be the same, but it's a different disease process that starts it, that's causing the pain. Rheumatoid is more of an autoimmune disorder that affects the joints, and it can actually affect other organ systems as well, but that's a little bit different than what we're going to be talking about, which is osteoarthritis. And then infectious arthritis is when you get, obviously, an infection in the joint that can seep from anywhere else in the body and can cause some damage to the cartilage, which is what osteoarthritis is. Osteoarthritis is a loss of the articular cartilage at the ends of the bone. And it leads to joint pain and stiffness that we all think about with arthritis in general. And that joint pain and stiffness can occur with any of those previous arthritic inflammatory arthropathies that we talk about. But the joint pain and stiffness is the sorry, I'll make a little pointer here, is the two main symptoms that people will complain about. So we talk about articular cartilage here. What is articular cartilage? It's a type of connective tissue that you can see that's at the ends of the bone. I've got a little drawing down here. And really, for these next few slides going forward here, to understand what osteoarthritis is, you really kind of have to break down cartilage, the articular cartilage. You have cartilage everywhere in your body, in your nose, in your ears. It's just a type, but articular cartilage is a special type of cartilage that is only at the ends of the bones of the joint. It's highly specialized cells that we're going to go over in just a little bit. But the articular cartilage is it's a very unique setup because it's a unique tissue because it has to be of these four characteristics right here. It has to be smooth, rubbery, yet firm and flexible. And we'll go through that in just a little bit. But, your joints are the cartilage is what makes the joints move. We think about knee and shoulder and hip is kind of what we'll be talking mostly about today, but it allows them to move smoothly because the functions of the cartilage is to decrease friction so that it is nice and smooth with movement, and to distribute loads. Think of it kind of as like the soles of your shoe to help provide a little bit of a cushion, and it'll kind of shift a little bit, very micro. You can't see it, but it helps distribute the loads across the joint when we walk or jump or do anything like that. Another thing that's unique about the articular cartilage is there's no blood vessels or nerves within the cartilage itself, which means that you're not likely to have any kind of healing going on if there's any damage to the cartilage. So it can't, heal or repair itself after any kind of injury, which we'll go over a little bit later. So you can see a little picture here. This is just kind of a basic, this is no particular joint. This is just the basic concept of a joint. You have the bones on either end. You have your capsule on the outside, and the little orange structure is your synovial membrane. That synovial membrane is what produces a synovial fluid, which provides the lubrication within the joint. That fluid also is how we talked about how the cartilage does not have any blood vessels, so it actually receives its nutrients from the synovial fluid that's produced by the synovial membrane. And then this blue structure on the outer edge, that's what we're talking about when we're talking about the articular cartilage. So here's another little slide. This just shows a little bit. I don't know why I put this in there as well, but it also shows the ligament on the outside. Ligaments are what provide stability with a joint. Ligaments connect bone to bone, and it's what gives you a lot of your stability in the joint. So the ligaments serve an important purpose. That's why it's another reason we'll get to a little bit later why it's so important to try to maintain a healthy joint and trying to stay active to keep these ligaments intact and functioning to protect all these tissues that are on the inside of the joint. Like I said, this is no particular joint. This is just your shoulder, your hip, your knee, your fingers, everything. All joints are a little bit different as far as what they do, but the concept is the same as far as this articular cartilage and being fed by the synovial fluid. So, all right. So, what is in articular cartilage? What is it made up of? So we talked about earlier, it's highly specialized cells. Now, if you are not at all science minded at all, you can ignore the next couple slides. We'll pick back up, but these next few slides does kind of dig a little bit into what the articular cartilage is made up of and what its role is in the joint. So the big component you have was what's called the extracellular matrix, and you have the chondrocytes, which is basically just a cartilage cell. And these chondrocytes and the matrix are all kind of intertwined, and we got some pictures coming up here shortly. But within the extracellular matrix, you have water, collagen, and the proteoglycans. Proteoglycans is a big word. It's basically just a protein complex within that cartilage. But these three, the water, collagen, and proteoglycans, all kind of work together within this matrix to help give it its structure. We talked about, I mentioned earlier, if you think about like the sole of a shoe and the helping distribute loads, as you move, you'll have, like I said, you can't really see it with the naked eye, but you'll have some water that shifts around to distribute that load across there. The collagen provides the structure and the framework and the tensile strength being stretched, and then the proteoglycans are what provide a lot of that compressive strength. So when you think about just the load, if you're standing up and you walk in that compressive load, that's what the proteoglycans are helping to provide that strength and that structure there. In arthritis, the collagen here will start to become disorganized. And I know there's a lot of words right here, but we got some pictures coming up soon that'll hopefully explain this a little bit more. But the collagen is what actually starts to become a little bit disorganized, and I promise you there is some order to it. And then the proteoglycans are kind of what they're kind of you'll see in just a second. They help regulate the fluid and kind of tell that water to kind of where to move around to distribute everything. And one thing I do want you to take a look at on here is that the proteoglycans have attachments for hyaluronic acid and chondroitin sulfate. Remember that for later on. Some of y'all may have heard some of that before. But these proteoglycans are what start to break down in the osteoarthritis. And then the chondrocytes are the cartilage cells that are kind of policing all of the matrix and telling these things what they need to be doing. Here we go. I told you we'd have some pictures. So if we look up here, this is the articular surface, so this is the outermost edge of the cartilage, and then we have the bone down here, if you remember from the picture a few slides ago. So we got bone going all the way up to the outer edge of the cartilage, and you'll notice it's broken down into zones. Now, I'm not going to go over all of this, but just know that within all of these, there's different zones, and you have the chondrocytes, which are these eyeball-looking things. And you have the collagen here, which are the stringy. And if you look closely, you'll notice that in each one of these zones, which we have the superficial zone, what's called the transitional zone, the radial or the deep zone, and then the calcified cartilage zone down here at the bottom. All of the chondrocytes, these eyeballs, look a little bit different in each layer. It's because they're serving a different purpose. If you look here, they're flatter, and as you get further down, they get rounder and rounder, and then down here, they're in these columns, and then they're getting bigger and bigger down here in the calcified cartilage. But in each one of these zones, they all serve different purposes, and you'll notice the collagen's the same way. It goes from being longitudinal here to kind of crisscrossing, and then to being straight up and down. But this outer surface here is what protects you from the shear forces. So if you think about a joint moving like this, I don't know if you can see that at all, but that's what's going to keep it as you move from that, moving across like that to protect the outermost surface. And then as you get deeper, it protects you more from that compressive load, the weight that you're putting on there. So just know that in each one of these zones, there's a different structure and a layout between the chondrocytes, the collagen, and the proteoglycans, and they don't get out of that zone. Think about the chondrocytes are kind of the police force to keep them in that zone and tell them what to do in that zone. Maybe not the best analogy, but hopefully you get it. And then here's just another slide just showing that and then actually this slide is showing the proteoglycans as well. These little purple things, that's the proteoglycans, those little protein complexes. I don't know how much of y'all remember from high school science or whatnot, but I've got a little slide for proteoglycans as well. But this just shows the different zones and the different types of cells and their structures and what they do. So here's a little proteoglycan, like I was saying. The key words here I want y'all to remember are the hyaluronic acid and the chondroitin sulfate. So you basically have this backbone of hyaluronic acid attached with the attachment for the link proteins, and then these long core proteins which have the chondroitin sulfate. So, and like I said, we'll get to this a little bit later. But some of the ways we try to treat arthritis non-operatively, meaning without surgery, are some of these supplements that we'll have you take, or some of the injections that we'll do with hyaluronic acid. So we'll get to that a little bit later. But just know that these are pretty complex. We're not going to get into all that though. So another thing, articular cartilage, it's not very thick. It's pretty thin. It's only about the height of about 2 dimes. The main takeaway from all those slides I just was talking to you about, just know that it's a highly specialized group of cells that all kind of work together in their own little world, in their own little zones. And it's important that in a normal joint, that all of those, all that is working together in what we call kind of homeostasis. It's just a happy little world. If there's any kind of disruption in that, then you can start to see some of those layers start to break down, and we'll go through that a little bit later. But it's just know that it's important that within the cartilage in each of those zones, it's important that they're all working together. The inflammatory arthropathy, like rheumatoid, that's when we talked about earlier, where you get the inflammation within that synovium, and that in turn can cause some changes within that cartilage just because it's so inflamed and aggravated, and the irritation can start that process. So moving on. So osteoarthritis, basically, degenerative joint disease is another name that we call it at times, and it's just a disorder of that extracellular matrix, like we talked about with the water, the proteoglycans, and the collagen. It starts to become disorganized. The chondrocytes, those cartilage cells, get bigger and they can pop, and then you'll have these enzymes within the disease process of osteoarthritis will start to cause some breakdown of that collagen and the proteoglycans. It can occur in any joint in the body. Most commonly that we see in the orthopedic world is with the knee and the hip and the shoulder, but there are some other joints. You can get it in your fingers, you can get it in your big toe. I've got a few x-rays later on that I'll show you related to that. So more pictures. This just shows the stages of arthritis, and we talked about the breakdown because, like we said earlier, osteoarthritis is the loss of cartilage, and it's the breakdown of the structure, the extracellular matrix that actually causes the loss of that cartilage. So in a normal, healthy cartilage, you've got this nice layer here within the superficial zone. If you look at these chondrocytes, they're all intact. All the proteoglycans are intact. Moving on to early stage arthritis, you'll start to see that you're seeing fewer and fewer of these chondrocytes. The collagen is starting to break down, and then the proteoglycans are starting to break down as well. If you can see, this compared to that. And then moving on to advanced OA, you can actually see where they start to break down, and the cartilage just starts to wear away. So why do we get arthritis? Several different factors play into why we get arthritis. These are kind of the most common ones. Age, just what we think about is normal wear and tear of a joint, but that extracellular matrix that we talked about becomes stiffer, and it starts to lose some of its stretchiness. So it doesn't give as much, and it just starts to shear away. Previous damage to the joint, that can include a fracture through the joint line, or a break through the joint. Any ligament damage, which can cause some instability within the joint, so you get some abnormal forces being put on the cartilage itself, or any other soft tissue injury with the knee, meniscal tears, which we're not going to really get into the meniscus on this talk, but meniscal tears, which help provide some cushion within the joint. If you have meniscal tears and you have to take away a little bit of the meniscus via arthroscopy, over time that can lead to arthritis, or just the meniscal tear itself if you don't do anything with it. The flap, the torn meniscus, which you think of as like a hangnail on the knee, can actually rub against the cartilage and cause it to wear away in that particular location. Obesity, just increased weight, but just makes sense. It just increases. It just means your joints are having to put up with that much more force and increased load on that joint. So, and over time, it just kind of gives out, for lack of a better word. Repeated stress doesn't necessarily have to do with weight, but increased weight on top of repeated stress can just make it progress faster. But repeated stress, so if you're doing the same, from a work environment or whatever, running, whatever, just repeated or any kind of repetitive movement over time can increase the shear and or compressive forces and cause that cartilage to wear away. And of course, it can be genetic. A lot of people with arthritis, they'll say their mom or dad or aunt or somebody had arthritis. They always heard them complaining about it, whatever. But certainly genetics plays a big role in as well. And malalignment, we're not really going to go into a lot of that, but some people will develop some what we say malalignment, especially in the legs related to the knee. But they can have an unbalanced load through the joint, and sometimes that can cause the arthritis if it goes on and on and on, because you get some abnormal wear where it normally should be balanced. And that's a little bit different procedure that we fix, and that's mostly in younger patients as well. But the big thing are age, any damage to the joint, weight, stress, and of course genetics. So symptoms are kind of multifactorial here. The big symptoms obviously are pain and swelling, and this occurs because, like those chondrocytes we talked about earlier, they'll pop in those chondrocytes, which kind of help direct the traffic within the cartilage. If they're non-existent, or if they start to decrease in number, then that matrix starts to break down, which leads to the loss of cartilage, which causes irritation of the joint, which leads to inflammation, and that in turn is what causes the pain and the swelling, because you get that irritation within the joint, and that synovial fluid, builds up trying to flush out the joint, so to speak, even though it can't flush out the joint. But the inflammation itself is what causes that pain and swelling. But the inflammation itself is also what can cause more irritation to the cartilage, and so it's just a process that goes round and round and round. Another thing is pain with movement. We talked about earlier, normal healthy cartilage, there's no nerve endings in cartilage. So that's why you can jump or in a healthy individual without any issues with their cartilage. You can do all your activities, run, jump, whatever, without pain, because there's no nerve endings in that cartilage. So they can rub up, against something and basically not feel it. It's just numb. But as you start to have that loss of cartilage, it progresses all the way down, and you get that exposed bone. Well, guess what? The bone has nerve endings. So as you get that increased friction, or that bone on bone movement, you get the exposed bone with nerve endings, and guess what? You got pain. So there's several things that can cause the pain, but the arthritis, the progression of the arthritis is something a little bit different. But pain, swelling, stiffness, those are the most common symptoms of arthritis. The pain, you'll see, it will typically be worse in the morning or after any kind of increased or prolonged activity. That stiffness in the morning, we'll call it startup pain typically, because if you think about it, that once you get down to and you lose that cartilage, you have the exposed bone, it doesn't glide as easily. So when you first get up, you kind of you'll find yourself pause and then have to take a few more steps to kind of work it out, so to speak. But you'll find that once you get going, you may get out of the chair, get out of the bed, and your first few steps are pretty bad. But once you get 10 to 15 steps in, it eases up a good bit. That's just another, that synovial fluid, which we'll talk about a little bit later on. It starts to distribute more through the joint and will help relieve some of that stiffness and get it moving. Decreased motion is another thing that you being able to straighten your leg all the way out, bend it all the way back in a normal individual, but in more of the severe arthritis, you'll notice that you can't straighten it out all the way, or you can't bend it back all the way. Of course, clicking, cracking, popping, all of our joints pop. Popping is normal. Painful popping is not so normal. But patients with arthritis, you'll get that clicking or cracking or creaking, and that's just that exposed bone that you're feeling, because you don't have that cartilage to help provide that smooth movement. So, and of course the swelling, like we talked about earlier, which is related to the joint irritation, inflammation, and it causes you to build up more and more synovial fluid within your knee, trying to, quote, flush out all that irritation, even though it can't. We usually, if the swelling's bad enough, we'll usually have to aspirate it in the office. So how do we diagnose arthritis? Of course, we're in orthopedics. We like to actually put your hands on the joint and feel it and do what we call a physical exam. So will ask you where it hurts. It's common in hip arthritis specifically. A lot of times people think if you have people think that if you hurt on the outside of your hip, on that bony prominence on the side of your leg of your hip, that you have arthritis. That's something completely different. That's more about your IT band issue. But patients with arthritic hips, they're going to complain of groin pain. They're going to point to the very front, deep part of their hip and say, "This is where it hurts." Patients with arthritic hips will say when they walk, it feels like somebody's stabbing them in their groin with an ice pick. So that's pretty classic for hip. With your knee, it's most commonly they'll point to the inside of their knee. But you can also develop pain on the outside of your knee or up underneath your kneecap. But they can typically sometimes pinpoint, but sometimes they'll just put a big old hand and say, "It just hurts. It just hurts." Crepitus is basically that creaking. We can put our hand on that joint and take you through motion, and we'll feel it. You may not be able to hear anything, but you can feel that crunching within the joint. And obviously, we'll look at range of motion, see if it's if you have full motion. And any deformity, people with knee arthritis, it's not uncommon for patients to become either knock-kneed or bow-legged. That's all related to where the arthritis is, and we'll go into that a little bit more. But if you have arthritis in both knees on the inside of the knee, you'll find that you'll be bow-legged, and if you have it on the outside of the knee, you'll be knock-kneed. But that's a pretty bad arthritis, not so much early on. And then if you have any instability within the joint, instability, we're checking the strength of the ligaments within your. Like I said, we're commonly through these next few slides, we're going to be talking about knee, hip, and shoulder arthritis, just because that's the most common that we see. But we're going to be checking for instability of your joints, which can either lead to some arthritis, or if the arthritis is really bad and you start getting abnormal wear, then you can actually create some instability because of the abnormal forces that you've been putting on the joint. And then we're going to get x-rays. Orthopods love x-rays. But specifically for arthritis, we're looking for the joint space narrowing, which we'll show here in just a little bit. Bone spurs. That joint space narrowing is actually, even though we're talking about the loss of cartilage, you can't see cartilage on an x-ray per se, but you kind of can, because it shows up as an empty space between the bones. So when that empty space starts getting narrower and narrower, then guess what? Joint space narrowing. It means we know that you're losing some cartilage there. So we can see that on x-ray. We're also looking for bone spurs. As you start to lose that cartilage, and the further down you get, and you get more and more to the exposed bone, and you're putting more stress on those deeper layers or deeper zones within that cartilage, your body will actually try to because of the increased load to that area, and it can't distribute it, like we talked about within that extracellular matrix, you can actually get develop extra bone. Your body will do that, kind of just some extra scaffolding. It'll try to outjut past the beyond the normal joint line to help distribute that load a little bit more. Sclerotic bone, that just means that bone becomes denser because it's being exposed to more and more stress, because you're losing that cartilage, losing that cushion. And we can see that on x-ray. It'll show up and we'll show you just a little bit, but where it just shows up as a little wider area right there at the joint line. And then bone cysts, we'll see that as well. That'll occur when you can get little micro fractures right there at the ends of the bone due to repeated forces and trauma to that area. Unrelated, I'm not talking about micro fractures with injuries or anything like that. I'm just talking about with the increased load, you can get some changes going on in that bone, and then it'll kind of resorb in certain areas and form a little cyst in the bone, and we'll see that in just a little bit. So the different stages, stage 0 equals normal. So these are normal x-rays of knee, hip, shoulder, obviously. And we talked about that empty space in between. So here on the knee, you got your femur. This is your tibia. This is your fibula. But the tibia is the big weight-bearing bone in the lower leg. And you can see the shadow back here. That's your kneecap or your patella. But this empty space right here, that's actually cartilage. Okay, that's not just empty space in between. I mean, there's a thin little layer, but there's actually cartilage on the ends of the bone here. And then your hip, same thing. Hip's a ball and socket. Hip and shoulder are both a ball and socket. You'll notice with the hip you have a much deeper socket compared to the shoulder. But you can see this nice layer around here of that empty space or the cartilage. Now in the hip, you have both cartilage on the outside of the femoral head, which is this right here, and you also have arthritis on the inside edge of the acetabulum or the socket. So you've got it on both sides, and the same thing on the shoulder. This is your humerus, and this is your glenoid right here. This is the socket of the shoulder, and you have arthritis on both ends of that. So, but you can see the empty space right here. So. In a knee, just the different stages. Stage 1, sometimes you can't really actually see that. The x-rays may look completely normal, and you may or may not be complaining of any pain, but just some early stages where you can get a little bit of that outer layer. We talked about the different zones of the cartilage. If it's just a little area of the outer layer that you're starting to lose, you may not be able to see that on x-ray. But it may be enough to cause you some aggravation, some inflammation, but you're still able to carry on with all your activities that you want to. And then 2, 3, and 4 progresses on where you start to get more narrowing of the joint. You can start to develop some little bone spurs, which we'll show you on x-ray a little bit more, and you'll start to see where you just get these little fissures in the cartilage they don't go all the way through, but it's just a little weak area, a little fraying, so to speak. And stage 3 starts to get a little bit deeper. You start to see some exposed bone, and then stage 4 it just starts to propagate from there. Now, anybody who has arthritis will follow a little bit different course as far as how. Sorry, I was reading some of these comments. As far as how fast they progress, some patients may reach stage 2 and never go beyond that. Some patients may take 5, 10, 15 years to go from 2 to 4. Some patients may do it in less than 6 months. So, that's all kind of multifactorial as far as how and why that occurs. But there's certain the slide a few back as far as what causes arthritis and as far as any kind of injury to the joint, genetics, weight, any of that can make it progress faster. But sometimes, I can't explain. Some patients may never reach past this. Some patients may go from here to here in 6 months. But let me see. I think we got some x-rays. Here we go. So this is a knee x-ray again. Back to this is a normal knee x-ray, normal joint space. You don't see any bone spurs, which you'd see on the outer edge like you do here. This is that bone spur we're talking about. You're starting to see a little bit of narrowing here in the joint here on the inside. Stage 3, you can see a little bit more, and you can clearly see here, this is what we call bone-on-bone arthritis, okay? Not just narrowing of the joint space, you have loss of the joint space. Typically these patients may hurt pretty bad, but, it's not that uncommon for us to see patients for the first time, and they're complaining of a little bit of knee pain, not too bad, and they have x-rays that look like this. Every patient's a little bit different. How they respond to pain's a little bit different. But just, the pain you have, you can be at any level of this. But yeah, so here are the different stages of knee arthritis. I think we got some hip and shoulder coming up too. So here's a little illustration of hip arthritis. You can see how you're starting to wear away right here, and as well on the acetabulum. So hip x-ray here. This is a normal, back to the normal joint space around the femoral head or within the joint itself. Here you can see the narrowing up here at the top. There's still a little bit of space there, but not much. This is one of those cysts I was talking about earlier. You can get these little subchondral cysts. Subchondral just means beneath the bone. Okay. When we talk about the arthritis, you have with the joint itself, you have the cartilage layer, which has the different zones. Then once you get to bone, we call that the chondral surface, and then that area just below that is what we call subchondral. So you develop these little subchondral cysts right here. The sclerosis, I don't think I mentioned it on the last slide, but sclerosis, this is that. See how white and dense that is right there? That's just denser bone. It's more mineralized, so it's going to show up on x-ray as white compared to more grayed out or black. Here's another one over here. You can see the decreased joint space. You can see the bone spurs here. This labels it as osteophytes. That's just another fancy word for bone spurs. But you can see the bone spurs here and then up here as well. And one other thing you notice is in a normal hip that this head is nice and round, whereas here it becomes a little more oval shaped, which is pretty classic for arthritis as well. Shoulder, again, normal here on the left, and then on the right you can see that loss of joint space. This is the bone spur. We call that a teardrop sign, which is pretty classic in advanced shoulder arthritis. And then you can really see how whited out this is, how sclerotic that bone is. That's a decent sized spur right there. All right, so how do we treat it? So we talked about how how painful arthritis can be, but what do we do to treat it? Well, we start simple. The goal with treatment of arthritis is to try to keep you active. What we don't want to do is, have you lay in bed or sit down and not be up moving, because then your whole body can start to decline after that. It's important to keep you active, keep your heart and lungs and everything working properly. So, like I said, goal is to keep you active. We always start with non-operative or non-surgical treatment first. And then, which several different layers of that, different facets of that, and then surgery. There's different options for that as well if it gets to it. So we start with the non-operative, non-surgical. Start with activity modification. So if you're a big runner, we might have you start backing off on that. But anything that you find that causes a lot of any certain activities that cause increased pain, we'll just have you back off on that. Like I said, if you're a runner, we may have you go to a bike or go to elliptical. But just trying to decrease the weight bearing activities that you do with that. Certainly weight loss. Even a 10 to 15% weight loss can make a significant difference on the pain that you have. It can you may think you're coming in and you're ready to have a knee replacement, and we may do a few things to start with, but if you're able to get some weight off, you may buy yourself a couple years before you need any kind of surgical treatment. So that's we don't just tell you that just to tell you that. It's proven to help you out. And certainly NSAIDs or anti-inflammatories. This can include your over-the-counter Aleve, ibuprofen, but we'll usually stick with either we like the over-the-counter Aleve, or we'll go to some prescription strength. Basically, it's less likely to have any adverse effects on your stomach, your GI system, and how often you have to take it. You know, Advil, ibuprofen, to keep it in your system, you got to take that multiple times a day. We try to stick to something that you only have to take once or twice a day. But those NSAIDs help reduce the inflammation, like I said, which causes the pain. The NSAIDs may not really do a whole lot for the arthritis itself, for the loss of cartilage, but it's just to help reduce the pain, and it may help if we can reduce that inflammation. It may help over time, may slow down the process a little bit, but it's more just to help with the pain. And certainly physical therapy to strengthen all the muscles around it. You know, we talk about, you know, your cartilage is basically the kind of like a shock absorber within the joint. But if you can strengthen up your muscles and make your joints more stable and let them become your shock absorbers, well, then the cartilage is not having to do as much. So certainly with physical therapy and trying to strengthen everything will certainly help you out. It'll also help you out if you get to the point where you need to have a total joint replacement, by if you can keep those muscles real strong, or as strong as you can. It'll certainly make the rehab process a whole lot easier on you after having your joint replaced, which is, we commonly, for patients that are going to be having a knee or hip replacement, we'll actually put them through a little prehab course where we do some rehabilitation beforehand, just to kind of get them prepared. There are these things, a brace is called offloading brace. We talked about, you know, with knees in particular, you can get, if you get the arthritis if it's more on the inside of the knee, then we can put you in a brace that actually takes some pressure off of the inside of the joint, and can help slow down the progression of it as well. And those will help out. They're not for everybody, but they will certainly help out as well. And then if you remember back from earlier when I talked about remembering the hyaluronic acid and the chondroitin sulfate, those attachments within those proteoglycans that help that protein, help make up that protein complex. As those proteoglycans start to wear away, you start to lose some of this chondroitin sulfate and the hyaluronic acid that was the backbone of those proteoglycans. So the theory behind these two, the over-the-counter glucosamine and chondroitin sulfate that we'll sometimes recommend, is just to help hopefully slow down that process of degrading, of the breakdown of that cartilage. But the chondroitin sulfate, that's an oral pill. And then there's a series of injections we can do as well. Steroid injections, obviously, we'll do in the office just to help reduce the inflammation. We typically try not to do more than about 3 within a year, just because over time they can actually cause some issues with the joint. You can do too much of it, so we try to reduce how many we do. And some patients, you know, it may last a year. Some patients it only may last 6 weeks, and a lot of that depends on where you are in the stage of arthritis. If you're early on, you can typically get by for a little while, but as you get more into that progression, more into the end stage arthritis, you know, you're going to find that the only thing that's really going to help sometimes will just be activity modification, where you're not really doing a whole lot. So the hyaluronic acid injections, that's you may have heard it called the rooster comb injections. It's an enzyme that they get from rooster comb. And actually, I think they're starting to veer away from that, the rooster comb, and it's all made in a lab now. But the hyaluronic acid is to help replace within those, like I said, those proteoglycans, is just to help slow down the degradation process of all that. And those hyaluronic acid injections, if you think of it, it's kind of like WD-40 for the joint. Just kind of helps lubricate the joint a little bit more. And like I said, with these injections, the more advanced arthritis you have, the less likely that you are to get any long-term relief from these. And then the PRP, platelet-rich plasma injections, that's something that we're kind of starting to do at times. We'll only recommend it in certain patients, but that's something we can do in the office as well. And again, it's just another one of those things that is hopefully will help slow down the process. There's no cure for arthritis. We're just trying to figure out how to slow it down right now. But this is These are ways that we'll try to treat arthritis without surgery, which we'll always try to do first. You know, we work in surgery, we make a living operating, but we don't operate on everything. So we always try to start simple first. We don't just jump right into surgery. Um, so, but if we do recommend surgery, sometimes we'll start with just an arthroscopy, where we put a camera in there and can see what's going on and debride any loose cartilage that's in there, or any fraying. We can try to smooth off what we can, but what's already fraying off, we can't put back. So we just kind of have to debride it there, and hopefully, in turn, kind of reduce the irritation and the inflammation in the joint. Arthroplasty, joint replacement, is what y'all may have heard of. In the different joints, you can do a partial versus a total joint, and that really just depends on the joint itself, where your arthritis is, and the age of the patient, activity level. You know, there's a lot that goes into that decision, but that's strictly between you and your surgeon, and it's certainly a case-to-case basis. And then we talked about earlier with the malalignment, those patients that may have just instability, or causing some instability because of that, the malaligned and some decreased abnormal forces throughout the joint. We can do a little procedure called an osteotomy, but that's only in the younger patients. Not super common, but it can certainly help a patient with very early signs of OA. If they have significant malalignment, that we can do a little procedure to prevent it from advancing any further. So on a knee scope, again, here's a lot of these pictures you'll see are knee. That's just because it's so common. Arthritis is so common in the knee. It's what we do most of surgical treatment wise, or knee replacements, followed by shoulder, and followed by hip and shoulder replacements for OA, that is. But so this is a normal joint. If you can see how smooth, this is the end of the femur here, okay, that the top bone, your thigh bone. You can see how smooth the cartilage is here. This right here, this is the top of your tibia. And you can see how smooth that cartilage is there. This is actually your meniscus, and this is a normal looking meniscus. This is just a little connective tissue here in the middle that you can get a little, that can tear as we get older, becomes more friable, but that's a whole nother talk. But I want to show you this just because so you can see how smooth the cartilage is. So that's a normal joint. Moving on, start to develop a little bit of early OA. You can start to see some fraying here on the top of the tibia here. You don't see any exposed bone. This is just kind of some softening and some fraying of that superficial zone of the cartilage. This patient also has a little meniscal tear. And who's to say that meniscal tear, it could have been going on for a while and could have been rubbing right up against this area and causing that irritation within that outer layer of the cartilage. Moving on, it can progress further where it starts to look like shag carpeting a little bit up here. It's just starting to fray a little bit more. Now this, I will say, this is obviously not the same joint. I don't believe this is not the same patient. It's the same joint. It's a knee, but it's not the same patient as these progress. But you can start to see where this starts to fray a little bit more up here, and we're getting into that deeper zone of the cartilage. And then here's bone on bone. This is actually exposed bone. So we have cartilage down here, a little cartilage here, but this right here is exposed bone. Okay. And we'll actually call this, we refer to this when they're in the same location, top and bottom, on the end of the femur and the end of the tibia. We call that a kissing lesion. So, so now on to joint replacements. I got a few x-rays here, just what joint replacements look like. This is a knee replacement. One thing I hope you can take away from this is that we really don't take away a lot of bone when we do joint replacements. In particular knee. This is the view from the side. We only take just below that cartilage level into the bone. We fit it. We have all kinds of guides in there to let us know what size you're going to need. That's going to be in surgery, that is. But we just take a little bit off the ends of the bone and just recap it with these implants that are typically made of titanium and cobalt chrome. But we just recap the bone. This is the end of the femur, and then the top of the tibia. Now, one thing you can't see, just like on a normal knee X-ray, that cartilage, you can't see cartilage on X-ray because it shows up as empty space. Well, we don't want this metal rubbing up against this metal here. So there's actually a little polyethylene, a heavy-duty plastic component that's in between these two implants, which the metal of the femur actually rubs up against. You can maybe see a little bit of the shadow of it right there. But that polyethylene, that plastic piece, comes in different thicknesses, so we can determine what you need while we're in there. That little polyethylene, that plastic piece, is important because if we put in too thin of a piece, you're going to have a wobbly knee. If we put it in too thick, you won't have all your motion. So while these aren't necessarily custom made implants, they are kind of fit just for you. It's not like we just take a small off the shelf or a medium off the shelf. They all come in different sizes, and we put it together as you need it. So this is a hip replacement. We have a stemmed implant that goes down the center of the bone here. For the first step when we do hip replacement, you'll notice we take out your native femoral head, the actual ball of the joint, and we put in a stemmed implant here that has a head that comes in different sizes. The acetabulum. Now, I will say with the hip replacement, all these are modular. So all these come in, the stem comes in different sizes, the head comes in different sizes, the acetabulum comes in different sizes, and then you can't really see it here because it's just like on the knee with that. There's a plastic component typically that will be on this inside here that the ball, which is typically ceramic, it can be metal or ceramic, will articulate with, but you can't really see that metal ball. I mean the metal liner inside there, but it comes in different thicknesses. But we remount the acetabulum or the cup to put a new cup in there, and then here's just another X-ray as well that you can see. Now, once you do a joint replacement, whether it's knee, hip, shoulder, whatever, the arthritis cannot come back in that joint. That's a question we get asked a lot. Once it's replaced, the arthritis is gone for good. That's because we we take out all the cartilage and get down to the bone up underneath it, and that's what the implants are fixed up in. So that's hip replacement. And I will say, these stems in here, your bones are hollow. You have the cortical bone on the outside and the spongy cancellous bone on the inside. So this we don't make this cavity. I mean, we size the cavity to figure out what you're going to need, but these stemmed implants go in a canal. This is called your intramedullary canal. It's right here, and it's already there. We're not making that canal. It's already there. We're just making space and figuring out what size you're going to need. So this is a shoulder replacement on the left here. This is what we standard shoulder replacement with where we replace the head. Again, we put a stem down the humerus, and then on the glenoid or the socket of the shoulder. Now, all these there's so many different companies out there that make implants. This one in particular, you have a metal screw, a little screw base that goes into the glenoid, but the actual glenoid implant or the socket implant is that polyethylene, that heavy duty plastic that doesn't show up on X-ray here. But yeah, you can see where we replace take out the arthritic shoulder, take out the head, remount the socket, and then put a new head and put a new ball and socket in there. This one on the right, It's a little bit unique. This is what we call a reverse shoulder replacement. Some people may have heard about it. You you can only do that in certain situations. We'll do it sometimes in fractures of the top of the humerus, or we'll do it in somebody who doesn't have a rotator cuff tendon intact. If they have a chronic tear, or they've had a tear before that's been repaired, and they've torn again, and they develop. It's not something we do just for a rotator cuff tear. You have to have the arthritis in addition to that. But for the standard joint replacement, you have to have an intact rotator cuff tendon to have the standard joint replacement. But for some patients who have those chronic tears, we'll do what's called a reverse. And it's called a reverse because over here, we're just simply replacing the ball with a metal ball and then replacing the socket. But if you look here, we reverse that. We actually put a ball on the socket side, or what is typically your socket side, and then we change that socket to the humeral side. And that, again, I'm not going to go into all that, but that's only for patients who don't have a rotator cuff tendon, because by doing this, from a physics standpoint, it allows the deltoid, which is another muscle, to kind of take over and do some of the work. You don't have to have a rotator cuff tendon to do this. So, other joints, like we talked about earlier, the knee, hip, and shoulder are the most common, but there are other joints that can commonly be affected with OA that we see here in the office as well. One of those is that at the base of your thumb, your CMC joint, stands for carpometacarpal joint. That's common in patients who may do a lot of knitting or crocheting, but they'll complain of pain kind of right at the base of the thumb, right down here. We see it, we treat it. We'll typically start just the same way with anti-inflammatories by mouth. We can do a little steroid injections there, A, to confirm that what's going on, that's where your pain is coming from, and B, just to give you some relief. But there is a neat little procedure that we can do for patients with this, that if it gets bad enough and persists and limits them, where we take out this bone right here, and we just take out that bone, and there's a few different ways you can try to you can suspend that open space, but it's a pretty neat procedure. But that's called CMC joint arthritis. Interphalangeal, it's your fingers. You can develop arthritis. So this is at one of your finger joints, like right here. This is normal, and you can see the progression, kind of like we did earlier, where you just have a complete loss of cartilage, and you're starting to get some deformity within that joint. Now, this is not to be confused with the joints that you'll see in rheumatoid patients, where they start to get significant deformity. This is typically going to be isolated to just one joint or multiple, but it's going to be very isolated. It's not going to be the rheumatoid hands that you see. We can fix this various ways, but this, it can cause patients problems, but it usually doesn't limit activity too much. A lot of times what we'll do is we'll just go in there when it's in some of these early stages. We can trim off some of the bone spurs, which can certainly be causing the patient's pain. Another location is in your big toe. We call it the hallux MTP, which stands for metatarsophalangeal joint, but it's just you can get arthritis in your big toe. You can see right here how you have that loss of cartilage there, and there's actually some little pretty neat procedures you can do for this sometimes as well. You can do little joint replacements, a little miniature joint replacement that we can put at that joint. Sometimes you just fuse the joint. You go in there and clean out the cartilage and you just fuse it. But that's a conversation that would be between the patient and the surgeon. And then in your spine, in a normal spine, you got your vertebrae, which are the building blocks, and then you have these little spinous processes, transversus processes back here, and there's facet joints in there. That's what allows your spine to move back and forth. And over time, you can develop some arthritis back here within these facet joints. Now, these alone don't necessarily cause pain and issues. It's very normal for patients over the age of 40 really to have some arthritis in their spine, but it doesn't necessarily limit. But as they progress, and if you can develop some instability, there are some little decompression procedures we do, but it's the knee, hip, and shoulder way more common than any of these right here that require any further work to be done. So take home points for arthritis. It's a loss of cartilage at an articulating joint, where the tissue breaks down at that cellular level. The chondrocytes and the extracellular matrix start to break down, and what leads to the loss of cartilage because it can't maintain the healthy structure. Can be caused by multiple things, most commonly age, genetics, or any kind of injury, damage to the joint, whether it be from a previous fracture, meniscal tear, ligament injury, whatever. Primary symptoms include joint pain and stiffness, and those can range anywhere from mild to severe. We see it all into the spectrum. And treatment is aimed at trying to keep you active, trying to protect and preserve the joint, like with physical therapy that we talked about, and trying to slow down the process of the breakdown of the cartilage. And the treatment consists of typically physical therapy, activity modification, medications we'll give you either by mouth or that we can inject into the joint, and then ultimately a joint replacement if need be. So let's see how we doing on time. Golly, an hour? I can really talk, can't I? It's one Dr. Savage and I do a little homeschool lecture, homeschool rocks on Thursdays typically. And that's one thing we found is that we can certainly talk. So if anybody has any questions, feel free to ask, or I'll also be checking back with this periodically over the next couple days. So if anybody has any questions, feel free to ask any ask any questions in the comment section, and I'll try and get to you and answer them. So. Thanks for watching, Jessica. Thanks, Elizabeth. All right. Nobody has any questions. Y'all, like I said, feel free to, if anybody's watching this later on, it's not live, feel free to put some questions in there and I'll try to get back to them. Otherwise, I hope everybody has a good day, and feel free. Like I said, we have some other lectures if anybody wants to check out. We've done, Dr. Dudman did one on shoulders, and Josh and Jennifer, our nurse practitioners, did one on osteoporosis as well. So hope y'all have a good day. Thanks for watching.